On this episode of Back and Brew, I'm excited to welcome back Dr. Jeff Marx, Chief Science Officer of Therapeutics, as well as a sommelier. He always brings compelling literature and science about products, as well as some type of drink that is usually outside of the bounds of what I'm used to. So I'm excited for this episode. This is Back and Brew. Well, thanks for coming on again.
Absolutely.
Great to see you. Thanks for coming back to Colorado.
I love the opportunity.
I am excited. When I saw that you brought in a brown liquor, I'm like, this is going to be a good Back and Brew. So yeah, I don't recognize this bottle, this name,
Great.
anything like that.
Perfect.
Do you want me to guess what it is?
Go for it. Guess.
Okay.
You'll be wrong, but give it a try.
You have the confidence my wife has in me, so
Yeah.
This is fantastic. So right when you poured it, I could kind of smell it from here, and I would say it smells like a bourbon finished in a rum barrel or a bourbon finished in a red wine barrel of some kind. So
Right.
That's what I get out of it. It smells,
And that's from this distance here, right? So
Yeah.
that's great. So what you're picking up is oak and I think probably some sweetness. So what I brought is Calvados. So this is an apple brandy from Normandy in northern France, right? So it's too cold for them to grow grapes, so they grow apples. And Calvados is cool because they ferment the apples and then they distill it and then they age it in barrels. So this is an XO. So depending on where you are in Calvados, XO means at least 6 years in the barrel. And so this is going to be blended from a whole bunch of different fermentations of different types of apples, different types of barrels. And so you get a lot of real fun complexity. But I think when you get ready to experience it, I think the apple will come through, even though it didn't quite get there from this distance across the table.
Yeah, you could definitely smell it. Yeah, well, cheers.
Cheers.
Yeah. Oh yeah, you can definitely smell it. But it honestly, it's not that off of a bourbon that's finished in some other sweeter barrel.
Yeah, so that fermented apple juice, the cider, has a similar sweetness level to probably what you're starting with your mash, but then you get all that influence of the oak. So here's a real fun little thing that for not just this, if you can hold it almost horizontal, and you can do this with lots of different spirits that are barrel aged, right? So because of the taper in this glass, this is not the glass I wanted, but this is the best I could get. If you now go and then just smell at the very, very bottom, as low as you can get in the glass with your nose, you're up too high. Go down way in the bottom. So you should be getting all fruit there, right?
Yeah, it's very, very heavy apple.
It's apple, but it's all kinds of apple, right? So there's
it's like green apple. You even get some of like
baked apple and apple pie and maybe a little bit of warm spice.
Yeah.
And then go back and do in the middle of the glass, move up.
Oh, interesting.
Now you're getting the oak.
Yeah.
Right?
Yeah, it's much more bourbon-y.
Don't go to the top, because if you go to the top, you just get all alcohol and it just blows your nose up. But you can do that same thing with any aged spirit if you have the right type of glass. And a Glencairn glass would have been my first choice here.
This worked really well. You could definitely tell a difference here. I would never have bought this. I would never have tried this. Someone would be like apple brandy. And in my mind, I think apple brandy, and I'm like, it's going to be some kind of like cheap bottle that bounces.
Undrinkable sweet stuff, right?
100%.
This isn't that at all.
And this drinks very similar to like a bourbon.
Yeah. So I'm a big cognac fan, and stylistically, it's pretty similar to a cognac. And in fact, the rules are a little bit different than cognac. So this is an XO, which means at least 6 years in oak. XO for cognac would be 10 years.
Okay, interesting. Yeah, it definitely has a longer taste, like it has a longer drawn out finish than a bourbon or even or any kind of whiskey.
Yeah.
But it's not necessarily hot.
Right.
Definitely very fruit forward. It honestly tastes like a really good bourbon that's been aged in a rum barrel. Is
awesome.
What it reminds me of.
Awesome.
Yeah. This much better than any sake.
Awesome. I'm glad you like it. Cheers.
Yeah. Well, cheers. Thank you. So obviously, if someone hasn't listened to our other episodes, they don't know why this is any kind of significance and why I'm so excited to talk to you about this and also about what you came on to talk about. You're the chief science officer at Therapeutics, best known for making iFactor and now Pearl Matrix. So those are two of the three drugs on the market that are indicated for fusion that we see used constantly in spine surgery.
Yep.
So, and the other thing that makes me excited about having you on for this is you also are a sommelier. What level are you?
I'm level 3.
Okay. And what are the levels again?
It depends because there's multiple different accrediting agencies and they all do different things. So at the very top level, there are the master somms. There's, I don't know the exact number, but 240 in North America. It's incredibly hard. I have no interest in ever doing anything close to that. But from where I am, the next level for me would be sort of like a degree program. And I just did it for myself because I love wine and spirits and figure the more I know, the more I enjoy. So I'm just going to keep studying informally from here forward.
See, you're the guy that I want to bring to most of the doctor dinners because you're going to bring something new like this. And it's kind of appropriate that you're with Therapeutics too, because again, what we talk about with Therapeutics is so far different than anything else that's out there.
Yeah, it's so interesting you say that. So the reason I developed my interest in wine and learning about wine was when I was a young executive, I was entertaining surgeons and taking them to dinner. And some of these guys have 2,000 bottle cellars at home. And working for a startup company with a limited budget, I had to try to find wines that would be interesting and good and they would be willing to drink with me. And I had to sort of learn and start chasing value and figuring that out. And from that point forward, the more I learned, the more I could enjoy and the more I could help people enjoy with me.
Well, hey, it's worked out for me so far.
Awesome.
So, Jeff, you're here to talk about Pearl Matrix, the new product that is released by Therapeutics. Tell me a little bit about how the handling of Pearl Matrix differs from iFactor.
Yeah, so in your experience, you've seen that iFactor putty performs really well clinically, particularly when it's well contained, right? That's sort of how it was designed. And iFactor putty has a water-soluble hydrogel carrier. So when that is placed in an uncontained space, once it hydrates, there is an opportunity that some of those particles might migrate. So in designing Pearl Matrix, we wanted to sort of A, overcome that, and then B, just sort of make it the optimal handling property for any clinical application the surgeon was going to want to use it in, starting with those in the lumbar interbody spine space. So we achieved that by replacing that water-soluble hydrogel carrier with a bovine collagen carrier. Because this is a drug-device combination product and we had to start from scratch with the entire IDE and PMA process, which included 5 animal studies prior to filing the IDE to start the clinical trial with the FDA, we'd started over with a clean sheet of paper and we re-optimized everything. So the calcium phosphate particles were optimized for their particle size, for their resorption rate, for their surface area and porosity, et cetera. We sort of re-optimized the process by which we bind the peptide onto the surface of those carrier particles. And then we optimized the collagen formulation and the ratio between the coated particles within that collagen matrix. So when that comes into the OR, it's a dry, sterile strip. It's hydrated and kneaded, and it becomes this beautiful compression-resistant putty. Per the study that was placed inside a PEEK cage and filling the interdiscal space around it. I don't believe I've mentioned this before, but Pearl Matrix has actually been approved in Canada for almost 5 years now. In Canada, it has a much broader indication. It's approved for most of the skeletal system. And we've seen it used in all sorts of places where postoperative migration could be a clinical challenge, but it's not. And we took the opportunity of having that commercial presence in Canada. We've actually done some prospective clinical studies, and you're going to be hearing more about those in the coming months and years.
Yeah, and I think even just kind of, and again, this is going to sound kind of repetitive, but I always think it's really interesting in how little people understand, including the surgeons themselves, of what actually goes into FDA indication for a bone product.
Yeah.
And the difference between a drug and any kind of other lower class of it. So just break down real quick, what are the different levels of classification per the FDA for bone graft?
Sure. Yeah, it's interesting. There's over 400 bone grafts marketed in the United States today, so that's sort of incredible in and of itself. There are 3 basic categories of products. So at the lowest level in terms of regulatory oversight, or what are called the HCTPs, or human cellular tissue products. So that includes the things you would expect. So minimally manipulated homologous tissue, say that 10 times fast. So minimally manipulated homologous tissue, so a cadaveric bone, cancellous chips, minimally processed. That makes sense, and there's a lot of those products. It also includes DBMs that are 100% DBM fiber that don't have a carrier. Adding a carrier turns it into a device. Those are also HCTPs. But the interesting portion of that category is all of the stem cell or cellular allograft products. Those are currently marketed as HCTPs. If you look at the regulations for HCTPs, that has 3 requirements. I already said 2. It has to be minimally manipulated. It has to be for homologous use, and it cannot rely on the metabolic activity of living cells for its primary function. So those of us looking at that would think maybe stem cells don't fit. In the middle, with a little bit more challenge and stringent regulation, are the Class 2 products. So in 1976, when Congress passed the Food and Drug Act and they created FDA, they created pathways to the market for drugs and devices. And there were tens of thousands of products already on the market at that point, and they sort of got grandfathered in. The FDA operates on sort of a risk-based system, and they've determined there's this class of products that are, of moderate risk. And so those can go through what's called a 510K. A 510K is the name of the document you file with FDA, but in that you establish that your product is substantially equivalent to a predicate device. So in the beginning, it was all of those grandfathered in devices, but there have been these sort of stepping stones. This product is substantially equivalent to that one, and they sort of move forward with more recent ones. For 510K products in the bone grafting space, there's one of 2 primary pathways, both of which rely on a single animal study. So for an extremities label, typically it's a 5 millimeter drill defect in a rabbit tibia. If you put the material in there and then the competitive or predicate device in there, and if the bone formation and resorption are similar, that may be enough for the FDA to grant a 510K clearance. So not an approval, but a clearance. If you want to have the word spine in the label, what is typically done is a posterolateral fusion model in a rabbit. So large New Zealand white rabbits. The product is mixed 50-50 with local autograft, placed in the posterolateral gutters. And again, you're looking to see if the bone formation and resorption are adequately similar to the predicate device. And that's the basis for the 510K clearance of the majority of the bone grafts that are marketed in spine today. At the top of the pyramid, the most challenging are drug-device combination products. And as you mentioned, there are currently 3 on the market today because that's the highest level of risk. So the hurdle there is much higher. So you have to actually do a prospective randomized level 1 FDA IDE clinical trial. And in that trial, you have to demonstrate safety and efficacy in accordance with the study design, the statistical methods, et cetera, that were agreed to with the FDA prior to the initiation of the study. So you lay the whole thing out, they approve all of it. You then conduct the study, and you have to sort of hit those milestones that you agreed to up front. That is an enormously different thing than an animal study or just sending the FDA a letter saying that I'm going to start selling this HCTP product.
And what is the cost difference, do you think, between those 3 levels?
Let me just sort of overgeneralize, right? So for the HCTPs, you could spend hundreds of thousands of dollars on laboratory testing, et cetera. I don't know that that's necessary. A first-class stamp is obviously a lot less than that. That's what you ask the FDA. But there's preclinical work that goes into establishing the safety protocols, et cetera. For 510Ks, those animal studies are at the high end in the $100,000 to $150,000 range, and an FDA clinical trial is in tens of millions.
So the very top of where the three products that are actual Class 3 medical devices that where 2 of them are Pearl Matrix and iFactor, that level, to be at that level and to do that kind of research usually is going to cost in the 8-figure range.
Yeah, so just the execution of the clinical trial alone is in the tens of millions. And then you add on top of that all of the development work, the validation, the manufacturing validation. So the PMA, which is what you file, so the IDE is the clinical trial itself, so investigational device exemption, that's the study. You then file a PMA, pre-market approval with FDA. So that is the document, hundreds of thousands of pages in this case. That includes manufacturing information, validation processes for test methodologies in manufacturing. Just the level of rigor is on a completely different level. 510K, you're really showing the evidence from the evaluations showing substantial equivalence. The FDA has the opportunity to, if they want, they can inspect manufacturing, but this all has to be locked down in a PMA up front. So manufacturing, validation, quality, and then the data from the clinical trial itself, and showing that you met those predetermined metrics for safety and efficacy. It's an enormous undertaking. It took us 12 years, and that sounds like a long time to most people. It was a long time, but this was the fastest this pathway has been completed in the bone grafting space by a wide margin.
And it's really interesting, like what you just said there. 99% of people have no idea that there's any kind of differentiation between the HCTP HCT/Ps and what's at the top of that, right? The class 3 medical device approval. So now let's just kind of break down for me the science behind Pearl Matrix. Why is Pearl Matrix so different than one I-Factor, and why is the P15 peptide, which is the drug inside Pearl Matrix, why is it so different than anything else on the market?
Yeah, so that's two big topics, right? So let me start with the peptide. So the P15 peptide is a synthetic replicate of a segment of the native type 1 collagen molecule. And collagen is the most ubiquitous biomolecule in all mammalian tissues, right? All of our connective tissues are largely comprised of collagen. But when the local cells sort of attach to those tissues, it's sort of at this little segment. So we have a drug company in California that manufactures that for us. And this little tiny peptide, we bind onto the surface of the carrier particles of either I-Factor putty or Pearl Matrix. Now, all of the cells that we're interested in for bone formations, whether they're undifferentiated mesenchymal cells, partially differentiated preosteoblasts at any of the stages of preosteoblastic differentiation, or fully differentiated osteoblasts, all of these cells have surface receptors that are looking for this P15 sequence. And when they find that, you can sort of think of it as like those P15 peptides are like keys. You plug those keys into the surface receptor locks on those cells, and that turns those cells on. So principally, first and foremost, it is an attachment factor. So it facilitates those cells attaching to the surface, but then it turns them on so they're activated. And that leads to an acceleration of bone formation. So not only do those individual cells be turned on to initiate themselves starting to form bone, but also all sorts of transcription happens, and those cells inside become little chemical factories, and they start making BMP, bone sialoprotein, alkaline phosphatase, and all sorts of other signaling molecules that tell other cells to come into the site and tell them, this is a healthy, healing environment. Let's go and make bone. That's enormously different from other technologies. Not only is it incredibly powerful in terms of turning those cells on, but the safety profile is amazing. In both our clinical trials, I-Factor putty was as safe as local autograft in cervical fusion. Pearl Matrix was as safe as local autograft in lumbar fusion. So your second question, or the first part of your question, I went backwards. You were asking about the difference between I-Factor putty and Pearl Matrix. The mechanism of action is the same. So the P15 peptide will attach and activate bone-forming cells, which will then accelerate bone formation. So that's the same. The indications for use are different. So I-Factor putty is approved for use in single-level cervical fusion. Pearl Matrix is approved for single-level lumbar inner body fusion. Our trial was done in TLIF, but we have gotten a PMA expanded indications now also for ALIF and lateral. So really any approach to the lumbar inner body spine where it's approved to be placed inside of and surrounding an inner body cage. In the cervical study, I-Factor putty was just placed inside of the cage, and that's important because it works extraordinarily well when contained. If it's not adequately contained, the water-soluble carrier can allow for some postoperative migration. That doesn't happen with Pearl Matrix. Pearl Matrix comes into the operating room as a dry, sterile strip. For the IDE study, it was just hydrated with sterile saline or Ringer's lactate. The scrub staff will knead it, and it becomes a compression-resistant putty that then in the study went inside of the cage and surrounding the entire interdiscal space around it uncontained. and that was as a straight up autograft replacement. So you couldn't do that with iFactor Putty. iFactor Putty works great in a cage, as you know you've experienced with your customers, but that intraoperative handling and postoperative site retention is enormously different. The mechanisms of action are the same, but then we could talk about their efficacy in their relative studies.
So it's really just an improved vehicle to deliver the drug.
It is, but we re-optimize everything else as well, right? So the carrier particle size, porosity, all those. There are more differences than that, but that's the principal difference that a user will notice.
Yeah, and absolutely. And coming from someone who's in the cases with that, I can tell you that's the one thing that, it's handling is such a critical part for a lot of these surgeons. And I'll be honest, most of the sales force probably doesn't dive into the science as much as some do.
Yeah, you said most folks don't understand the differences in the regulatory pathways, right? And that includes surgeons, sales reps, hospital purchasing people, et cetera. So, right, there's all these products available in the hospital, and everybody sort of looks at them as being the same because they don't know, right? And the only way to fix that is through education, and that's what we're trying to do. So once surgeons understand the difference in the mechanism of action of our two P15-based products, they want to be able to leverage those advantages for their patients. And now there's multiple ways for them to do that now with the approval of Pearl Matrix.
Yeah, no, I was surprised at how fast it hydrated and how well it stayed together as well.
Yeah, that took some development, but we were really, really pleased with, surgeons seem to really appreciate that.
So kind of walk me through exactly how did you guys even figure out that P15, like what P15 is, it's trademarked or it's patented?
The original foundational patents have expired. It's been some time. So it was really discovered in the late 80s and into the early 90s. So there was a gentleman named Raj Bhatnagar, who was a professor at UCSF. And he was sort of researching collagen. And we all think of collagen as being the sort of rebar that provides mechanical properties to our tissues. And it is that for sure. But in the last several decades, we're starting to learn that also has a lot of really important signaling properties, wherein it can provide signaling for local cells following an injury response and as tissues are being developed, as well as sort of modulating the acellular matrix around that in those various tissues. So as he was digging into that, he discovered that there's this little segment that causes cellular attachment and activation. And it's interesting. Collagen is a triple helical molecule. 2 of the 3 strands of the triple helix are alpha-1 chains. They both contain the P15 peptide. The alpha-2 chain does not. But in native tissues, those are sort of twisted together. And then those molecules are together into the form of fibrils. And those are twisted into the form of fibers. So all of that P15 is buried down inside of that structure so that the cells really can't see it and interact with it. They only have the opportunity for it to become bioavailable and activate cells if it's torn during an injury response. And so when cells come in post-injury, that's sort of the first signals and messages they get to tell them what to do. Or when collagen is cleaved by collagenase, it's sort of right next to the segment of the collagen where that lives, and it becomes exposed and available there. Or if a surgeon implants either iFactor or Pearl Matrix, there's all kinds of this peptide directly on the surface of those carrier particles right there to tell the cells what to do.
Interesting. So it's really kind of playing off of like the best way to see that in action in nature is if there's an injury.
Yeah. Although, arguably there's a much higher concentration and bioavailability of P15 on the surface of particles of our 2 products than there would be in the event of an injury response.
I mean, but that's really what we're doing in spine surgery anyway, right?
You're creating an injury, correct?
Yeah.
And the body can respond to injuries in different ways. Sometimes it responds in exactly the way you want and makes the tissue you want where you want. And then there's the other times where it sort of does the best it can given the environment.
How is P15 a safer drug than the third product that is a class 3 med device on the market?
Yeah, so let me try to talk about this sort of globally, right? So there's a couple of things that are different. First and foremost, the P15 peptide has to be localized. right? It only works if it's bound under the surface of carrier particles. And so it only works in the site where it's implanted. So there's no action at a distance. So that's one. Two, it's a little tiny molecule. 15 amino acids is really, really small. And so its efficacy is very, very specific. And then finally, the sort of modes of action that it turns on within those cells are sort of pretty narrow. And they're largely focused around local regeneration of bone, improving that local immune environment, and recruiting additional cells in to sort of join the party. Other drug technologies have more mechanisms of action that may lead to different results. And the concentration is also an important part of that safety profile. So what I'd really like to just point out with regard to safety, in our 2 FDA ID clinical trials, so prospective randomized FDA monitored level 1 trials, in our cervical study, I-factor putty was found to be as safe as local autograft. In our TLIF study with ProMatrix was found to be as safe as local autograft in that very, very rigorous study design. So I think that just sort of speaks for itself.
And I definitely want to get into your guys' Aspire study because I think it is very compelling. And I think it was really well done, really well designed.
Thank you.
Kind of risky too. But just to kind of finish off and summarize that. So a lot of times we've looked at efficacy as in terms of, well, will this product grow bone in a muscle pouch? And the downside to that is it'll grow bone in a muscle pouch.
Right.
So you're saying with the P15 drug, it stays local to where it's supposed to grow bone.
Yeah, so it's where the surgeon implants it, right? And ectopic bone formation is one of the potential adverse events that can occur in spinal fusion, right? And it's not helpful to the patient, right? You want the bone to form where you want the bone to form and not elsewhere. So the P15 peptide will initiate that bone forming cascade in the presence of all the cells of the osteogenic lineage. We have actually purposely implanted it in soft tissues in animals in both the I-factor putty and the ProMatrix form. It does not form bone in those soft tissue sites. We think that's important for safety because that's not what you want clinically. I've always found it interesting that DBMs have always been marketed on the fact that, it's osteoinductive. We know that because it makes bone in the muscle pouch in an animal. I don't know that that's really what we should be using as the criteria for showing efficacy, right? Efficacy in human beings is really what we ought to be searching for. And that combined with safety is incredibly important.
Yeah, but what you're talking about is extremely expensive too.
It is expensive. Not every technology deserves that level of investment.
And it's fair. Like I mean, there are 250 companies now that make a pedicle screw. So you can imagine the slice of pie available is so small that if you're going to go out there and you have the opportunity to get your product to market for $10,000 worth of research, or if you really want to get the good clinical data and really run a high-end study that is risky because if it doesn't turn out right or in favor of your product, it could kill it, you're going to pay starting at $10 million. It's a pretty clear. I understand.
Yeah, for an IDE and PMA, you're in the tens of millions, right? So pedicle screws, as an example, those are 510K, right? So the principal pathway to approval there is largely around the design integrity, biomechanical testing, et cetera. So it's largely a sort of a biomechanics exercise, whereas I don't think people think the clinical outcome are dependent on which pedicle screw was chosen. I think choice of pedicle screw is largely based on surgeon preference for the instrumentation and how comfortable they are with their representation, supporting them in the OR, which is incredibly important.
I've had this conversation with multiple surgeons before. There are very few things that we use in the OR that really are differentiated. And the P15 drugs in I-factor and now ProMatrix definitely is one of those things that I'll say reps almost fight over because they're like, I can't replace that. If a surgeon does any research, they realize it's really hard to replace.
Yeah. We like to say that, hardware is temporary, right? Use the very best hardware that you are comfortable with, but its job is to perform provide temporary mechanical stability. So the surgeon is doing a decompression and likely realignment to address the patient's neurological challenge due to decompression. That decompression has to be stabilized in the short term with hardware. But if they don't achieve a biological fusion, eventually the hardware is going to fail. So, it's always often described as a race between getting a biological fusion and hardware failure. The best way to be confident that you're going to win that race is to choose a product that has been shown to accelerate bone formation and ideally in an FDA clinical trial. And as of right now, as we're speaking, there's only one that can do that.
So, because what is it classified now? It's a bone growth accelerator. Is that what the new verbiage is?
Yeah, so we describe ProMatrix as a bone growth accelerator, and that is based on the demonstration of faster fusion that we achieved in our IDE clinical trial. And that was only because we designed the trial in a way to show that. You were asking about, it started off this section of the conversation about trial design, et cetera, and there's as much art as there is science to it, right? So the principal goal of doing an IDE and a PMA, if you have a product in that classification, is to get approval so you can start marketing the product. That was a goal. It was incredibly important to us, right? We weren't going to spend tens of millions of dollars and hopefully not get to the end and get an approval. But we felt, based on our experience with iFactor Putty and its clinical use worldwide since 2008, showing extraordinary clinical results as well as safety. We also, all of the work that we did with the preclinical studies with iFactor or with ProMatrix in the lead up to starting the study, we were pretty confident we would show faster fusion than autograft. And so we designed the study in order to show that. We did that by measuring fusion at multiple time points starting at 6 months. So 6 months is pretty early to start looking for fusion. And we also chose to measure fusion by thin cut CT only. So that's not how fusion's measured, in the real world, out in standard clinical practice. It's usually plain films and flexion extension. Thin cut CT is much more rigorous, tends to lead to a smaller numerical value for fusion, but it's much, much more discerning. And it's much more sort of scientifically valid and rigorous. So we started with fusion assessment at 6 months by thin cut CT. If the patient was deemed to be fused by the independent blinded radiologists, done, we stop. You want to limit the radiation you expose the patient to. But if they weren't fused at 6 months, we tried again at 12. If done. If they weren't, we took a final one at 24 months. So to my knowledge, nobody's ever designed a clinical trial in order to try to show faster fusion. I don't know that anybody's ever been confident that their product would show faster fusion to justify sort of the risks and costs associated with that study design.
And I definitely want to dive into the study because from the first day that Sean Lesage, who's one of your guys' best sales guys, hands down, when he first brought the Aspire study to me, he was kind of talking me through it briefly, and he had mentioned the patients that were selected for the study and the comorbidities and kind of the rate of how you pick them. And I thought he had made an error at how the selection was made.
Yeah.
So kind of go into the Aspire study. It was done on, was it 293 patients?
Yeah, 293 patients, and you're asking about high risk. So, there's some principal risks to fusion, i.e. pseudoarthrosis, and among the highest on that list are smoking or nicotine use, diabetes, and obesity. And there's pretty good literature showing that the increase in pseudoarthrosis rates are surprisingly high, which each of those. We thought it was important to design a study not just to lead to approval and the ability to market as I described. We also wanted to show that we could achieve faster fusion than autograft as sort of the standard of care. And we wanted to show that this works in the actual patients that are coming into surgeons' clinical practices. And so as we were selecting sites to participate in the trial, so we decided to allow inclusion of diabetics, smokers, and obese patients. And we actually tried to select sites that we thought were going to have sort of rich populations of those patients. And we got through the entire enrollment, and it turns out 62% of the patients enrolled in the study were in one or more of those risk groups. So that's you could say a pretty big risk to the study that most other companies have not been willing to take. But we thought it was incredibly important to show not just sort of the healing power of the technology, but surgeons could make a clinical use decision for next Wednesday's patient and not try to extrapolate from a study done on healthy patients that may or may not translate.
So you have a study where there's 62 patients that have at least one comorbidity of being smoker, obese, or type 2 diabetes.
62%.
62%
Yep.
of them had one or more of those.
Yep.
What was the procedure done?
So it was a TLIF. So for those who aren't familiar, this is a lumbar inner body fusion, and the approach into the lumbar spine was roughly like this. So transforaminal lateral inner body approach. So TLIF is arguably the most challenging approach to the lumbar inner body spine in order to achieve fusion for a couple of reasons. One, the surgeon doesn't have real good direct visualization, and part of success of achieving a biological fusion is doing a really good job of end plate preparation. So removing all the cartilaginous material from the vertebral body end plates so you can get bleeding bone and sort of the healing potential coming in from the adjacent vertebral bodies. That's hard to do in a TLIF. So if you look at sort of the fusion rates in the literature of various approaches to the inner body spine, TLIF is the most challenging. So study design was single level TLIF using a smooth peak polyethyl ether ketone cage. So there's a lot of different cage materials available that all have sort of, their own benefits and drawbacks. Peak is great because it has an elastic modulus similar to bone. It's radiolucent, so you can evaluate fusion radiographically, but it's sort of dead plastic. It does not participate in the healing process. And then there's some instances in which the patient sort of has an adverse immune response to that, and you can get sort of a fibrous encapsulation tissue around the cage, which will then lead to that being between the cage and the bone. So that is deleterious to achieving fusion. So we chose the most challenging approach. We chose the least useful technology for the inner body spacer in terms of its biological participation in the fusion. We allowed diabetics, smokers, and obese patients. And then we evaluated fusion by thin cut CT, which is more challenging than the other approaches. So we didn't take the easy path here.
And I can tell you in 2015, we sold tons of Peak still. Now we sell almost zero pure Peak.
Yep.
Even the Peak that we do sell is textured or has something done to it to where it's a roughened surface. Sometimes they have porous Peak.
Yep.
But largely companies have abandoned Peak and have gone to either tie-coated Peak, titanium, 3D printed titanium, something that's not Peak, just because of that reason of that fibrous tissue that can develop around Peak and cause non-unions ultimately. So you go in with a population that is extremely risky to have a fusion study done on. So 62% have one or more comorbidities. They get they get a procedure that is not typically known as having the highest fusion rate, right? TLIF, great procedure still, but if you're going to go TLIF, lateral, or ALIF, TLIF is definitely going to be on the bottom of as far as fusion rates go, and on the top of non-unions.
Yep.
And then what did you measure?
So we measured a lot of things, right? So the FDA study actually had a 5-point composite endpoint. So that's not what's done in clinical practice, right? So the composite endpoint included radiographic fusion, so that surgeons are measuring fusion. So radiographic fusion, which was assessed by thin cut CT, functional score, which was the Oswestry Disability Index. We also measured neurological success, which was sort of no new or worsening neurological deficit, adverse events, and then subsequent surgical interventions at the index level. So each one of those are measured independently according to predefined metrics and the FDA criteria that we agreed to. But success for any individual patient, they had to be successful for all 5 of those components in order to be successful. So in our study, which was a non-inferiority trial design, so we had to show that they were not statistically different in that composite at 2 years, that would have been success. So we designed it in a way that once we demonstrated non-inferiority, we could then measure for statistical superiority. So that was included in our uh, predetermined and FDA-approved statistical plan. So not only did we show non-inferiority, we actually showed statistical superiority to autograft in that composite endpoint. So most of those measures, ODI, neurological success, you don't expect that to be a function of the bone graft chosen, at least in that time point. Did the surgeon do the right surgery? Did they achieve a good decompression and address the neurological problem? And they did in both arms, so those weren't different as anticipated. But fusion, you do expect to be a function of the bone graft chosen. We, in fact, showed statistical superiority in the fusion rate at 24 months. We also, if you look at a survival analysis of the fusions over time, we were actually able to show to the FDA satisfaction faster fusion than autograft. So there are enormous numerical differences in fusion rate at all 3 time points. One thing we really like to point out is at 6 months, more than twice the patients were fused in the ProMatrix arm as compared to the autograft control. And the autograft almost caught up numerically at 2 years to where ProMatrix was at 6 months. But in the meantime, ProMatrix continued to improve. So enormous changes and improvements in faster fusion. And we think faster fusion matters for patients. We think it matters for surgeons in managing their clinical practice, et cetera.
Absolutely. Now, just hearing that and not seeing the study, someone might be like, okay, so why? I mean, what was the TLIF procedure done? Where was, did someone use a little bit of autograft and a lot of ProMatrix? Did they use, 10 cc's of autograft and 1 cc of ProMatrix?
Yeah.
How was that regulated? What was the standard for that?
So great question. One thing I forgot to mention in the study design was we allowed both minimally invasive and open TLIFs. About 50% of them were done minimally invasive. So the protocol was very, very clear. So I mentioned earlier, they were to fill the PEEK cage and the entire interdiscal space around it as much as possible in both arms. We wanted these patients to fuse and be successful clinically. So what we did is we provided a 10 cc unit of ProMatrix to the surgeon for every procedure. They filled the interdiscal space and cage as best they could, and then they captured and recorded how much they used. And across the entire study, the average used per patient was a little bit over 7 cc's.
And they didn't put any into the posterior lateral gutters or anything?
No, so that's another thing I didn't mention about the study design that sort of increases the challenge. A lot of TLIFs are done with an accompanying posterolateral fusion. So we refer to that as a 360. We did not allow any bone graft in the posterolateral gutters. The surgeons were allowed to decorticate the facets, but they were not allowed to put any exogenous bone graft in the facets. So this is an inner body fusion only. They did use pedicle instrumentation, but again, inner body fusion only. So we provided 10 cc's. They used as much as they could. Somewhere in the 7+ cc's was the average across the study. And in the autograft arm, they used the local autograft from decompression, fill the cage, fill the interdiscal space around it. If they couldn't get enough graft on their approach, they could supplement that with cancellous chips. And the volume of graft used in the control arm was very similar to that of the ProMatrix arm. Sometimes we get asked, did it make a difference if cancellous chips were added versus just the local autograft alone? We've done post hoc analysis on that. There was no measurable difference in fusion there. So that, it's a reasonable question to ask. We showed that did not lead to a difference. We also did not show a difference if you tried to correlate the volume of graft used versus fusion rate, because that's sort of self-scaled to match the patient, the geometry of their implants and how much of a space the surgeon was able to create with their decompression and adjustments.
Oh, absolutely. I mean, if you're doing the difference between disc space between an L5S1 and 4.5 is very different. And depending on even the patient, you get the body habitus, and there could be a huge variance there. So to recap it, you took probably the most difficult patient population to fuse with the most difficult procedure to do for fusion, and limited where they could actually decorticate and place bone graft, or sorry, you limited where they could place bone graft.
Yep. And we use peak cages.
And you used, most people would say, the most inferior product for fusion, which is peak cages.
Yeah, wouldn't everybody do that same study design?
To be fair, the surgeons that you used for the study had to really believe in P15 in general, because that would be.
Yeah, so that's an interesting observation. So this study design is outside of some people's perception of what standard practice would be, right? So a lot of surgeons aren't comfortable doing a TLIF without doing a posterolateral fusion. That's just part of it. They feel more comfortable with the belt and suspenders. I think that's completely reasonable. And there were surgeons who declined to participate in the study because of that. And that made sense for everybody. That was completely fine. But they had to believe in the protocol, and they had to believe that the technology was going to lead to good outcomes from their patients, because at the end of the day, whether they're participating in a study or not, they're responsible for that patient's outcomes.
Yeah, it's very different than the rat model, right? Or I'm sorry, than the New Zealand rabbit model.
Either, right? Both.
Yeah. It's really interesting because we obviously carry a bunch of different companies. And I've been out to different companies where they're like, well, we have a study that's absolutely going to destroy the therapeutics, study. And it'll be like a bench study or a rat model or something like that. So I kind of wanted to talk about, there are a lot of competitors out there that have a product that handles similar, or if not in some cases better than Pearl Matrix, that looks the same and is a synthetic, and they will say, well, it's just collagen. So it's collagen. You said yourself that collagen is what contains the P15 protein, or the P15 peptide. Why not use that?
A couple reasons. One, so I described the structure of collagen, right? And how the peptide is buried down inside of those strands. It contains the P15 peptide, but it is an almost immeasurably small amount, and it is not bioavailable to cells. So it's effectively a passive matrix. Of the 400 plus bone graft products that are on the market at a wide variety of price points, I think if you think about value in medicine, right? So value is providing a predictable or meaningful clinical result at a reasonable price. And if you have a product with amazing handling properties and whatever else you're ascribing to it, it has a magic surface morphology or whatever that might be, if you don't have high quality, meaningful clinical studies that are going to demonstrate that the surgeons should be able to achieve something in their patients with it, that's overpriced at any price, right? Animal studies don't translate to humans. Poorly designed and conducted clinical studies, and specifically with products that don't resorb and you can't differentiate between them and new bone, those do not create value, even if they're provided to the hospital at an incredibly low price, and they're not usually provided at a really low price.
I agree. Anything that we sell, I always look at, do I believe in it enough for my family to have this done to them? It's one of those things where I'll always go back and look at the data, right? I don't know anything about hips and knee replacement, right? So if I were a patient, or if I had a family member who was a patient, the first person I ask is another rep.
Yep.
And like, who's the knee guy? Who's the knee guy to go to? Who's the knee guy?
Right.
And then I ask them why. And I think to a large extent, therapeutics can kind of have that clout in the discussion around bone graft, because there's so much white noise out there. No one wants to talk about bone graft. Usually a surgeon will look and be like, well, what helps out my implant rep? When in reality, like what you said, the implants are temporary, right? They're meant to hold that segment in place while the biological process happens to fuse and to grow bone. So you guys have a very compelling product, fantastic study. I think you guys are going to take over the world with it. You're going to get too big for us, and that's all right. I hope you guys absolutely take over the world with that product, because the Aspire study was phenomenal. That was one that was very hard to shoot holes in.
No, I appreciate that. Like, we knew at the time we were taking some risks, but they were risks that we were very confident made sense and we're going to pay off in the end. And here we are on the backside, and it all worked out, right?
It's interesting too, because even though I did say, therapeutics will get too big for small distributors like us at some point, it is amazing how the commitment from therapeutics to stick to distribution, and it really kind of shows that they're sticking to development and to innovation. Whenever a company's getting positioned to sell, you'll usually see the innovation stop. All projects stop. Anything that's going on, a study with a surgeon stops. And it's amazing to see that you guys are still pushing the limits. And it's great to see from someone who works with, I think we contract with 53 different companies across Vine. We really like partnering with the companies that say, yeah, but maybe this could be better.
I appreciate that. So we have an incredible commitment to education, so we partner with fellowship programs. I spend an awful lot of my time traveling, doing grand rounds and other sort of types of educational events, and I have peers that do the same. We're also not resting on our laurels. We're continuing to do clinical research around the world. So the United States is a different environment than most of the rest of the world in terms of our regulatory pathway for drug-device combination products. So we continue to do clinical studies, prospective and otherwise, outside of the U.S. We will continue in the U.S. as well. And we have fun and exciting things planned for the future that we're not ready to talk about yet, but we're not done.
That's awesome. I can get pre-IPO stock at some point. Then is that what you said? That was where I promised?
I don't think I said that.
Jeff, I'm going to try to find any reason for you to come back on, because frankly, you always bring something really interesting that I would never have bought. This I will buy again. Like, that is
awesome.
That is phenomenal.
So fun thing about Calvados, so it's not just great sort of as a sipper, but it's really fun for cocktail making. So just sort of imagine this sort of apple backbone to a cocktail. You can sort of drop this in almost anywhere you would choose to use bourbon or rum, and or cognac even, right? So lots and lots of things that you can just sort of noodle on.
Yeah. Out of curiosity, what's the price point on this? Like,
I don't remember. I think it was in the $70 range, but you can get them far less expensive. So XO is the longest aging classification that they have. So that's a minimum of 6 years, but it can be more. But there's Calvados that are aged for much shorter periods of time, and you're going to sort of taste the difference in terms of the oak influence, just like you would with any other brown spirit. It was phenomenal. Well, I'm looking forward to getting one of these, and also using more Pearl Matrix, going through, you guys went through the regulatory pathway. Now we're going through the hospital approval pathway. Sean has done a great job in supporting us in that. Come out with another product, or another study, or for any reason to come back here at all, I am more than happy to have you on. Sounds great. This is fun, and it'll be fun to do it again.
Absolutely. Thanks, Jeff.